I'm going to take you through what we did around evidence-driven response for COVID-19 in Africa. This work was to come up with rapid response in different areas that I'm going to talk about, really to try and create that science policy interface. This was mainly evidence review for the COVID-19 outbreak that is still with us. So a lot of it was to do with discussions with various policy makers, stakeholders, drawn from a broad spectrum of expertise. So we had epidemiologists, global health experts, mental health experts, academia, and of course, the wider community as we sent out, invitations to all these groups. And one of the things that we did was to carry out series of teleconvenings virtually. And this was really to co-develop the research questions, frame the problem so that it suits the different needs and the policymakers. And then we did a lot of rapid evidence synthesis based on the prioritization of each particular research topic. And of course, the evidence was geared to improve the continental and national preparedness and response. And then thereafter, we did a production of policy briefs. So we had about 7 areas. One was around transmission, epidemiology and surveillance, diagnostics. Some of it had to do with how you characterize clinical cases and mental health. We also had one on drugs and vaccines or clinical trials. We looked at broadly impact of COVID-19 generally on health systems. And of course, social science and policy research. And one of the things that we did was to look at how vaccine uptake, or what you call vaccine hesitancy, plays out in the continent. So I'll just take you through in terms of how we obtained this evidence and why these key areas, because they were quite interrelated and they were quite significant, for African countries to build a very synergistic approach in terms of building back or building better from the pandemic. So when it comes to transmission dynamics and epidemiology, one of the key sources of evidence was around the models that have been used to track and, of course, guide the response of COVID-19. And we saw a number of models have actually been used both directly and indirectly. Some of them guided how decisions were being made. And then in terms of diagnostics, we looked at what are the testing approaches or more of surveillance ways that have been used, which test approaches were quite significant, which ones were underdeveloped. So these were sources of evidence around models and methods around how COVID was tested. And of course, some of these methods, whether self-reporting, antigen testing, some of these methods actually informed, the recovery rates, advisory measures to be put for the emergency. Then when it comes to how cases, clinical, characterizations and how cases were identified, scanned, so a lot of evidence came from existing frameworks, and more particularly how research has been done on the continent. You are aware that we had, previous diseases like Ebola, and a lot of evidence came from, those existing frameworks around how clinical cases, characterized the comorbidity issues, how you deal with mental issues. So a lot of it came from, the existing frameworks and the research that was being done around what is currently ongoing. For example, if you look at mental health and how this community, self-organized community mental, I could call them experts, supported, recovery or response to people who are challenged mentally. And then when it comes to clinical trials, a lot of evidence came from the committees that were constituted. So we saw a number of committees in the continent or in different African countries that were constituted in order to support or fast track how vaccines are perhaps regulated. We saw expert committees constituted to do a number of pharmacological or pharmacological vigilance systems. And then the other topic that we did was to look at impact, of COVID-19 generally on health systems. And a lot of literature or evidence came from published literature. We relied on evidence from broad databases. We could call them global COVID-19 case information. So we had,
we had
other international bodies like CDC, WHO, and a lot of evidence was around how we could have accurate, precise modeling systems for the health system, so that there's better public health planning and intervention strategies. Of course, when it comes to social sciences and policy research, again, evidence came from learnings from previous pandemics and a number of it around stakeholder participation. And then when it comes to vaccine hesitancy, where did the evidence come from? So a lot of evidence was on, self-evidence through social media, because this is where we are seeing misinformation or information being provided. And all these plenty of information circulated. And so another evidence also was more anecdotal evidence from healthcare workers. So broadly, these were the sources of evidence in this broad spectrum of areas. So what did we learn about the key enablers and disablers of evidence? One of it is that politics is an enabler of this evidence, more particularly expert committees. But again, it could be a disabler of evidence because of personal considerations, driving evidence so that decisions are made. The other key enabler we thought really enable evidence use, evidence emerging is different models of how evidence is obtained. So we had a lot of these expert models relying from WHO and other experts. Based on that, some decisions were made because this is quote unquote experts. And then we also saw not so much participation around citizen science, where the citizens inform the evidence. So what we are saying is that in different areas, there was a pluralistic model where you have the expert, the citizens coming together to generate evidence. So this was a key enabler because where such occurred, then you had uptake. And then the other thing is around informal rules and practices, things that are actually just made political pronunciations. And these are quite informal in their nature, but in one way or the other, they enabled evidence uptake and use. Then we had another enabler, which is about external influences in policy direction. So these experts advising how countries should either talk about lockdowns or vaccines. So these external influences have been an enabler for policy uptake. And then the other is about multi-sectoral and collaborations across science and policy. So bringing all experts and having everyone sit at the table, this is one enabler of evidence use. And of course, mobilization across generations. And by this, I mean the young, old, middle. So this was another enabler of evidence, really, to bring about health and social systems reform. So lastly, I just want to go through the lessons learned. How do we move forward when we want to improve evidence, not just for COVID-19, but even for disaster, other emergencies to come or other challenges? One, from the model and from our learnings from COVID, is really to create that demand for evidence. Because when we went through needs assessment, prioritization, we have learned that uptake of the way evidence is used is more about the demand. So if we can create more demand for evidence through one or two ways, I think we are able to improve how evidence is taken up or even used. The other one is about consultations with the users of the evidence, but again, with the people you are creating this evidence for. And these are the communities, the poor, the rural, etc. And then we need to be very deliberate on how we frame the evidence, because once we realized with COVID-19, evidence was needed in specific areas, in specific context. So we need to be very deliberate how we frame this particular evidence. Then the framing really determines how that evidence will be taken up and used by policymakers. Then the other is about knowledge translation and practice. And when it comes to knowledge translation, it's about how do we relay and convey this messaging once we've done a rapid synthesis from complex to simple, granular information that can be taken up. So we need to strengthen how we translate the knowledge and even at the practice level. The other issue is about timeliness. So for COVID-19, really, it was about, I could say, rapid, quick evidence needed. And we saw evidence generated, perhaps not tested, but that evidence was quite timely for uptake. So this is one of the ways we can improve. And then lastly, what we realized is really a lot of creating a science policy that is really pro-poor or focused on people who are not included. And one example I can give this is in Malawi, where we saw lockdowns being implemented without consultation or without thinking about the poor, and there are court cases because of this. So when we are generating evidence for use, we need to see how it interfaces with the poor or pro-poor, neglected, and bring that element of inclusion. So I think that's all. This has just provided a high level information on what we did, but there's a lot of material and information that can be found on the link. Thank you very much.